Now I'd like to call upon stage Dr. Rajesh Kamble sir to present on inguinal region and external hernias.
Warm morning to you all, and I think at the outset, let me thank all the organizers who have called us upon from Mumbai to speak on this dais. A big congratulations to Pondekar sir's team. I think it feels very special to come to Aurangabad. I think way back in 2006 when I had started practice, Sabu sir had invited us and we had come to Taj Aurangabad. So it's been now 20 years, so feels very good to come here. I think the topic I'm going to talk is about hernias. Now, let me at the outset tell all of you all that I'm an ultrasound guy and who performs ultrasound with a lot of passion. CTMR I have left to Srinivas Desai sir, so I don't interfere in those fields. So let's get on with the talk. So basically, when this talk of hernias was given to me, a lot of hernias came into my mind. Because hernia is nothing but protrusion of a bulge or an organ through a structure or muscle that usually contains it. So all things ran into my mind. I do a lot of fetal ultrasounds, so I thought of physiologic herniation of gut, which we see as early as 10 weeks. Then the diaphragmatic hernias, which we pick in antenatal life. So you all must be doing a lot of ultrasound right from fetal till the male adult. So CDH, which we can pick up very confidently in antenatal life. Heart, stomach seen in plane and gives a clue to the diagnosis. Also, when we do fetal ultrasound, we come across gastroschisis, omphalocele, and those are also a type of hernias. So, but when you talk about abdominal hernias and external hernias, when you do scanning, it could be just a part of your abdomen pelvis scanning, or it could be a specific clinical request from your clinician that this patient, I think it's hernia and you need to give me an answer on ultrasound. Or they could be just asymptomatic and you pick them up while doing part of your sonography. Or a patient would just palpate lump and come around. Now, I think you all must be using convex transducers to evaluate abdomen pelvis. But today, when we talk of hernias, when you want to evaluate, the spectrum has completely shifted. We use high frequency linear transducers in our day-to-day imaging. So technology has brought us into a big leap. We have very, very good high frequency transducers which can pick up hernias very, very well. So the topic was hernias inguinal as well as external, and this is all about the anterior abdominal wall, which has multiple layers right from skin, then the muscle layers, transverse abdominis muscle, transversalis fascia, peritoneum. So these are the 9 layers of abdominal wall. If you have a compartmental approach step by step from outer to inner, you will be able to pick up everything and anything in practice. So this is the way you sweep when you do your scanning and try to start evaluating the abdominal wall for any kind of hernial defect in day-to-day practice. So hernias could be anything. The one which we have been given talk is about abdominal wall hernias, which could have varied things right from the location. The inguinal ones, which you see very common in day-to-day practice, the incisional ones, which come up after surgery, the special ones, the Spigelian, epigastric, which you could encounter in a day-to-day clinical practice. So basic hernia is, there is some defect in the abdominal wall. Most commonly is the transversalis fascia, through which the hernia comes out. So I'm going to skip these slides because of paucity of time. But in day-to-day practice, if you look at modalities to evaluate hernias, we have ultrasound, CT and MR. And I'm going to talk about ultrasound because it's widely available. I passionately practice. It's non-invasive. You can use it in pediatric and adult age group. And I think the best part of ultrasound is dynamic evaluation. It's real time. So you're not going to miss anything because you can do Valsalva's maneuver. You can tell patient what you want out of the study. You can see the patient supine standing, which cannot happen in CT-MR, and pick up the defects really, really well. CT is SIRS area. So if you look at all the hernias right from top of the abdomen till down, right from umbilical, epigastric, hypogastric, paraumbilical, and the Spigelian ones, which I told you. So Spigelian one is that special one which usually picks up on CT where there is defect in the linea semilloralis. So day-to-day practice, I think you all must be seeing this kind of defects where the patient comes for abdominal scanning and you see that there is a defect and there is this pouching out, something like this, and you know you're dealing with umbilical hernia. But that's not important. just to pick up a hernia. The surgeon has lot of thing which he expects in your hernia report. What is it? One is he wants you to locate the hernia, where exactly it is lying. Second, he wants to know the size of the defect. Most importantly, as a clinician, he wants to know whether this hernia is reducible, irreducible, size of the defect, because he wants to repair the same. Contents, I think you can confidently today evaluate on ultrasound. So there could be an omental fat, there could be bowel, there could be anything within it. And the best part is, if at all the patient comes in an acute setting to you, you can always tell the clinician that whether this is obstructed, this is irreducible, and also if at all the blood flow, today on Doppler, you can evaluate and tell it that it has got strangulated. So these are all what the surgeon expects from you. I was talking about this special hernia which affects across the defect in the semilunar line, resulting into this special type of hernia. To be honest, only one I have seen in 20 years practice, which was confirmed on CT. So this looks something like that, where the defect comes out. Almost it's one of those lateral hernias which you would come across. So the location is very nice. You need to know that there is basically a transverse band which lies between both iliac crest, anterior superior iliac spine. So it's a line run there where this Spigelian fascia lies. And you will see that the patient typically will say that there is a pouching coming out and you have hit the diagnosis of a Spigelian hernia. But trust me, if this could be suspected on ultrasound and definitely confirmed on a CT. Then the most common ones which you will hit in day-to-day practice, and how are you going to pick it up as a radiologist? Very, very simple. And everyone needs to remember only one artery, the epigastric artery which comes out of the external iliac. Anything lateral to the epigastric vessels is, unless proved otherwise, an indirect hernia. So indirect will always course through the inguinal canal, come from the deep inguinal ring to the superficial inguinal ring, and those are the indirect ones seen in day-to-day practice. The direct ones are always going to be medial to your epigastric vessels. They are the defect in the Hesselsbach triangle, and they're usually seen in the elderly age group. And the femoral one, by its name, you need to see the common femoral vein. Anything medial to that, you see a defect and a pouching, you can confidently label it as a femoral hernia. So I'm not going to again talk into this because I've been told to restrict my time, but this is a simple clincher in day-to-day practice. You want to diagnose an indirect inguinal hernia, the hernia which goes through deep inguinal ring, comes to the superficial inguinal ring and reaches the scrotum, has to be, unless proved otherwise, an indirect hernia. And it's usually seen commonly in these younger males. As against, direct hernias are basically the weakness of the posterior abdominal wall and the Hesselsbach triangle defect, through which the hernia just protrudes out, and commonly seen in an elderly age group. So anything medial to inferior epigastric vessels, I endorse, will be a direct inguinal hernia unless proved otherwise. Now what leads to these factors could be potential defect or weakness since you are born. It could be prematurity. It could be basically you doing any strenuous activities, especially elderly age group where they have bladder outlet obstructions because of BPH, and patients then lands up with a hernia and comes up with a palpable swelling. So direct hernias, one should always remember, because it comes through the Hesselsbach triangle, it will never usually get strangulated because the defect is large. As against, the indirect ones go through the deep inguinal ring, come down, go into the scrotum. They are the ones which can potentially get strangulated. Then I'm not going to talk much on this because of restriction of time. Now, the key to all this on ultrasound is basically dynamic examination. So whenever we do ultrasound, we talk to the patient, explain him the Valsalva's maneuver. We evaluate always all hernias in supine and standing position. No examination is ever complete before evaluating the hernias in a standing position. So not going to talk much on this. So search the inferior epigastric artery. Once you have searched that, your job is very, very simple. Medial to it, right direct hernia. Lateral to it, right indirect inguinal hernia. So this is a direct inguinal hernia. Large defect coming out. In fact, see in this case, beautifully we could see that even the bladder was herniating down. And this is typically an elderly man who came with this direct inguinal hernia. And then the typical ones which you all must be picking up in your practice, the indirect ones which goes through the deep inguinal ring. And then it can have varied contents. So once it has that omental fat which goes right from the inguinal ring into the canal and then it enters the scrotum, then the terminology changes. You call it as an omentocele. Then once if at all you have seen that this patient had large swelling on the right side. So see here, such a large hyperreflective mass, inguinoscrotal in location. Looking at this content, we could confidently tell the surgeon, this looks like an omentocele. As against, there could be bowel lying within it. So bowel, I think you all have developed a pattern recognition of picking it up. And if at all you see bowel something like this within it, you know that this is nothing but an enterocele. So the definitions will change, and that's the way you're going to report it in your day-to-day practice. Femoral ones, in my 20 years of practice, I have seen couple of few, but typically females having a swelling near medial to the femoral vein, and they come usually with severe pain, and most of them have very tendency to get obstructed. So the femoral ones are very cryptic. You need to listen to the patient's history very, very carefully. Then, as I was telling you, always do Valsalva's maneuver. Now that Valsalva's maneuver itself is such a tough job, patients don't understand what is Valsalva's maneuver and land up doing a lot of mistakes. So even if you tell the patient to bloat his tummy well, you will be able to pick up these hernias in day-to-day practice. So this is one was femoral hernia. I have seen very rare femoral hernias in day-to-day practice. Now, what is very important is this take home. How are you going to report it in your day-to-day clinical practice? So one is that you're going to talk about right and left inguinal canals. You're going to talk whether this hernia is reducible or irreducible. Because the surgeon damn wants to know whether this hernia is reducible, then I will operate at a leisure. But if it is irreducible, he's going to plan his OT early. Second is whether it's obstructed, non-obstructed, right side. Then nowadays, because of ultrasound, we can see the defect. So we say that the defect is small size, large size. Then as I said, we always tell the surgeon, this is a direct hernia, this is an indirect hernia. And most important, we always punch in that these are the contents, small bowel loops, omental fat. And today with advent of Doppler being used in high frequency, always have tendency to use everything what is there in your machine. So if you put color and you see wall vascularity within the bowel, you know that this bowel is viable. And then you can say that this is an enterocele and this has definitely not got strangulated. So this is the way we report everything. We always make the patient stand and confirm our findings. Then other than that, there are these large list of differentials. If you read about hernias, right from if there is a stoma created, there are parastomal hernias, there are lumbar hernias which occur below the 12th rib, the superior and the inferior ones. Then there are these weird hernias which I have not seen in practice. One of them is this sciatic hernia through the sciatic foramen obturator. So name of the foramens, and through that anything can herniate. In fact, there are these internal hernias also which occur near the paraduodenal areas. So very beautifully picked up on CT, I think. Litters is one where there is herniation of the Meckel's diverticulum, and the interparietal ones which occur between the facial planes of the abdominal wall. So see this interesting case, patient had undergone appendicectomy, right iliac fossa, and came with a palpable lump exactly near the area of the right iliac fossa. When I started seeing it, I could pick up this defect. I could demonstrate that something is coming out through this defect in the RIF. I had never thought that in RIF also hernias occur. I read that yes, interstitial incisional hernias can occur along the right iliac fossa, and this case proved the same. Now when you're going to, there are going to be hernias, there are going to be huge number of complications. So right from irreducibility, obstructions, strangulations, anything can occur. But most important, the surgeon wants is strangulation and incarceration, where he needs to go in and operate immediately ASAP. So see this case beautifully, you could see obstructed irreducible hernia, something like this. The hernia just did not go back. But what's clinching in this case, whenever you see fluid trapped within an obstructed hernia, it gives you a secondary sign that yes, this hernia definitely looks obstructed. So see this acute abdomen, inguinoscrotal, patient come with severe pain in an acute emergency at Karuna Hospital. And when I started evaluating it, see the bowel had completely got trapped, something like this. And see the bowel loops were also dilated and obstructed. We raised a possibility of strangulated inguinoscrotal hernia, which got proved the same. This lady was sitting on this hernia for many, many years, did not bother. Such a big lump with this defect, we could see beautifully on a convex transducers. Here the high frequency did not help us, and this was an obstructed irreducible hernia lying with her for many, many years, and patient got operated for the same. Again, obstructed left inguinal hernia with bowel loop seen within. Obstructed Spiegelin hernia. Then nowadays when these surgeons operate, there are complications related to the repair. So one could be immediate and late ones. So the immediate ones are very interesting. There could be day 2, day 3 seromas. There could be these seromas, then there can be slippage of the ligages, and then they'll end up with these hematomas, something like this. Even these hematomas can get secondly infected, and then they'll end up with big abscesses like this. Nowadays, laparoscopy is used everywhere. So port hematomas can also occur and patient can land up with you. But most interestingly, nowadays meshplasty is done by the surgeons, and there they place either the mesh above the transversalis fascia or below transversalis fascia. See, this case taught us a lot, where abdomen was normal. In fact, this was a very old lady. She refused, saying that there was no surgery done. The relative said, हाँ कुछ तो एक hernia का operation हुआ है. But when we started evaluating this, we saw that all along her abdominal wall, she had this puckered kind of defects. But what beautifully ultrasound demonstrated that there was a mesh which was lying like this. She had this hitched up hypoechoic lesions all along. See all along how beautifully you can get mesh. But see, the mesh is not seen in continuity. It has got buckled at many places. Whenever you see something like that, always thinks in terms of an meshoma. So meshoma is a entity which has come up since the laparoscopy has come up in a big way. So depending upon where these surgeons place the mesh, sometimes this mesh can undergo non-fixations and insufficient fixations, and then they get buckled up and crumbled, and you can beautifully pick them on ultrasound. So this is one article which endorses that how you can pick up meshomas in day-to-day practice. So just concluding is that abdominal hernia can have varied appearance. I think I love ultrasound is because of its dynamism. It's also that you can perform Valsalva's maneuver, which you cannot do in CT, supine standing, which completes a surgeon's clinical angle of looking at a hernia. And always in your reports, talk where the hernia lies, talk about the contents, use all the things in your machine, use Doppler judiciously, because you can't tell the surgeon that this hernia is irreducible and strangulated. You need to go in and operate. Thank you so much for your attention.
Thank you, sir. That was a wonderful lecture on inguinal region and hernias. I would like to request Dr. Ajay Jadhav, sir, to felicitate Dr. Rajesh Kamble, sir.
As always, it is a great experience to hear Dr. Rajesh. He is one of the eminent speakers we have around. And as usual, his lucid talk is very important for all the nicer points, tips he gives us. And the most important thing we should keep in mind always for any routine USG abdomen also, we should use high frequency probe. Always you have to use, and whenever there is a suspicion of hernia, one should go for supine as well as standing procedure. Thank you.